Hello and welcome everyone to our latest journal review on ventilator weaning and discontinuation practices for critically ill patients. It's a global study on epidemiology of weaning and discontinuation practices published in JAMA recently. The incidence of invasive mechanical ventilation ranges from 270 to 310 cases per 100,000 population. This incidence is expected to increase in the futures. The invasive mechanical ventilation increases the complexity and the cost of healthcare. The cumulative exposure to invasive mechanical ventilation has been associated with potential harmful co-interventions like sedation, increased morbidity due to ventilator-associated pneumonia and lung injury, long-term functional sequelae, and cognitive impairment. Thus, limiting the duration of invasive mechanical ventilation has been identified as a priority area for research. The objective of this study is in critically ill patients who have been intubated and receiving mechanical ventilation was to describe the ventilator weaning and the discontinuation practices all over the world, to investigate association between discontinuation strategies and what outcome the patient develop, and to identify factors with the use of select discontinuation which are associated with success and failure. Now, it was a prospective, multinational, observational study. The patient population was all intubated patients who were admitted for at least 24 hours. They were prospectively followed up by the research personnel. Patients who were excluded, if they were transferred to a participating ICU without the documented intubation time, they underwent a tracheostomy at the admission, were already using the ventilator settings compatible with spontaneous breathing trial, were at participating ICU for 24 hours or more, were readmitted during the study period, or participated in other studies with explicit weaning protocols. Now, the data collection. The data was collected from November 2013 to December 2016. Patients were followed up until successful extubation or disconnection, that is tracheostomy, death, or ICU discharge or transfer, until day 60 for patients with ventilator dependence. Sample size. Data was planned to collect at least 10 discontinuation events other than death in each of the 150 participating centers. Now, this was based on the fact that they wanted to achieve at least 212 SBT failures, that is a spontaneous breathing trial failures, anticipating that at least 50% of the discontinuation events would evolve an initial SBT and 70% of which would be successful. So based on this calculation, they wanted to take at least 10 discontinuation events from 150 participating ICUs, that is almost 1500 events, so that they can get 225 SBT failures. Now let's see what were the results of the study. So 2,506 patients were assessed in the 142 ICUs screened for inclusion. Out of this, 638 were excluded, 202 because they didn't give consent, 148 because they had already reached the 10 upper limit, which was the maximum number of patients a particular ICU can enroll. 101 had tracheostomy at admission, 96 did not have an intubation time, 54 were transferred before discontinuation event, 31 undergoing spontaneous breathing trial settings currently. So out of this, 1,868 were followed up and 363 patients died during the discontinuation event in this study. So the data includes 424 patients who underwent direct extubation, 150 who underwent direct tracheostomy, 930 who underwent spontaneous breathing trial. Out of this, 461 was initial success, 169 had an initial failure, So if you look at the demographic data, so mostly it is men, one third men. The age is around 60 years across all the settings. SOFA is around 5. Type of admission is predominantly medical. So elective surgical admissions are very less. Only patients who were directly extubated had a higher incidence of elective surgical intubation, which is quite expected. The reason for intubation, decreased level of consciousness was one of the important reasons to intubate the patient. Operative was one more important reason. So a lot of patients were there who were intubated because of operation. So as you can see, direct extubation was more in post-operative patients, which is again something which is expected. Hypoxia, hypercarbia, that is respiratory problems, were in around 25% of the cases. Cardiac arrest, airway patency, other reasons are given over. Now the primary diagnosis, most of them had a primary diagnosis of acute respiratory failure. Neurologic was around 25%, post-operative was around 20%. Now ventilator support at ICU admission, invasive ventilation was in 60%, non-invasive was being tried in 35, bilevel in 4 and rest. Now the type of hospitals which were enrolled, most of them were university hospitals, university affiliated hospitals. 14% were community and 5% was community without any physician in training. Now type of ICUs, again mostly medical or surgical ICUs. Multidisciplinary is 23%, only medical is 7%. ICU was predominantly managed in a format of closed ICU, almost 71.8% was closed ICU, nearly 30% was open ICU. Now, the total duration of mechanical ventilation was 4 days. This is the overall total. But if we see at different groups, the patients who were directly extubated in only 3 days. Patient who underwent tracheostomy, it was as expected longer, 13.2. And who underwent spontaneous breathing trial, it was slightly longer than the patient who got directly extubated, 4.1 days. Now, patients who did not die and patient who died, they divided the group into two parts. So, if the patient who did not die had a lesser days, but as expected, the days were more with tracheostomy and less with direct extubation and spontaneous breathing. Similarly, patient who died had a longer time on ventilator. ICU mortality was 9.2%. 4.7% for direct extubation, 10.3% for spontaneous breathing trial. So clearly the patients who were being directly extubated were less sicker patients. Direct into tracheostomy, the mortality rates were high because these were probably neurologic patients or patients who are very sick who could not be weaned off. Hospital mortality was almost similar in all the groups. Mechanical ventilation day at day 28 was 6.7. For direct extubation, it was only 2.6. For spontaneous breathing trial, it was double. And for tracheostomy, they were totally on ventilator as expected. Now, ICU stay 31 days, 6, 35 days for ventilator patients, for tracheostomy patients, and 10 days for spontaneous breathing trial. Now, as expected, patient who died had a longer stay in the ICU. Similar with the hospital stays. Readmission to ICU before hospital discharge was 5.3%, and it was same across the group because once they are extubated, they're almost the same population. Reintubation was 9%, 9.2% for direct, and 10.4% for spontaneous. So, irrespective of what method was used for extubation, it was the reintubation rates were similar. Obviously, the tracheostomy patients were not reintubated. Now, based on the success and failure, And the duration of stay, they had divided the two groups, that is the spontaneous breathing trial group who had success versus who had failure. Now the first division is based on the success and failure, that is in this the duration of mechanical ventilation was 3.5 days in patients who had success, and 6.1, that is double, in patient who had failure. So these patients required 3 more days, 2 to 3 more days of ventilation before they could be extubated. Mortality rate was double again, clearly showing that the patients who were requiring more time on ventilator were more sicker. Similar findings with hospital mortality rates, because it is expected once the patient is extubated and sent to the wards, the mortality rate is going to be the same. Mechanical ventilation days at day 28 was similarly less in success group. Mechanical ventilation days at day 28 was less in success group and 11.7 in the failure group. So obviously they required more days on ventilator. Similar findings with all the other stays. Readmission rates were, again, as I said, similar once the patient goes to the ward, and even the extubation rates are same. Now, based on the timing of initial breathing trial, this is they took 2.3 days, as if the patient underwent spontaneous breathing trial before 2.3 days, it was taken as early, and beyond that was taken as late. Now, based on that, they divided the patients if early or late. In the early, the success was 2.1. In late, it was 6.1. And similarly, the mortality rates were higher in patients who underwent a trial late. And ICU length of stay was more, the hospital stay was more, similarly with all the findings. Now, looking at what were the protocols in the different hospitals, mainly screenings for spontaneous breathing trial readiness. They looked at the various ways by which the patient were being intubated, whether there was a sedation protocol, whether there was a sedation scale. And in this, they have divided the presentation into all the patients and different regions. So mostly there were 6 major regions or countries by which they had divided. It was Canada, India, UK, Europe, Australia, New Zealand, and US. Now, if you look at the overall, daily screening for spontaneous breathing trial readiness was being done in 46.4 centers. Now, many centers were not doing a daily screening of the patient. Mostly in Europe, daily screening is not being done, while in the rest of the places, it is more highly reported, especially US, India, and Canada. Now, conduct a spontaneous breathing trial, it is 43%. Similar findings because it is lesser in Europe. Adjusting support during weaning, it was more commonly seen in US. During weaning process, they were adjusting the support. Sedation administration, sedation scales being monitored were very high. Almost 80% of the centers are doing this. Almost very high adherence from India. Daily sedation interruption, again highest from India, while these are less reported in the Europe and Australia countries. Delirium management, almost in 50% of the centers. Early mobilization, again 50% of the centers. There is a gross geographic distribution difference in all these parameters, especially in terms of early mobilization, daily screening, and conduct of spontaneous breathing trial. Now, who was doing the daily screening? Predominantly, it was being done by the intensivist. Now, the spontaneous breathing trial was being conducted again mostly by the intensivist. Though there is some difference of practice, especially in Europe, in US, it is mainly being done by the and respiratory therapist, US and Canada, which is not the practice in rest of the world. Now, the adjustment of the ventilator setting was again mostly done by intensivist in major countries. In US and Canada, it is mainly done by the respiratory therapist. which is one of the major difference which has been found. Now, looking at the mortality rates and all, the ICU mortality rate was roughly similar. In US, from Australia, the data is very less, so probably that is why the mortality is so low. Mechanical ventilator days were almost similar, which is very less in India. Now, this is for patients who were successfully extubated. Now, ICU mortality rates are similar across the group, and re-extubation and re-intubation rates. This is for patients who underwent successful extubation after a spontaneous breathing trial. But one of the surprising findings is, even though re-intubation rate is around 11% for these patients across the world, from India it is 0%, which is sort of surprising. Now, patients who were in direct extubation and direct tracheostomy, the same findings. As again, the rates from India are very less, especially the re-intubation and the readmission rates. And mortality rates are roughly similar across the world, except in India, where the rates again tend to be quite less than compared to rest of the world. Now, the limitations of the study. Data was collected from 169 spontaneous breathing trials, which was 75% of the target. They were targeting 225, but they got 169 failures of SBT. This data was descriptive, and analysis was not adjusted to patient characteristics. So it is presented just as is. As I said, the severity of the disease can affect all these findings. It doesn't mean that the patient is more on ventilator, that is why the patient is having problem. The patient is having problem because the patient is more sick and requiring more days on ventilator. That is why the patient's outcome are worse in patients who are not getting off ventilator early. It doesn't mean that the ventilator is at fault. It is a disease process which is going inside the body. Although the eligibility criteria enabled inclusion of a diverse cohort of critically ill patients in whom invasive mechanical ventilation was discontinued, using several strategies, the use of a different time threshold of inclusion, that is 12 to 48 hours of invasive mechanical ventilation, and limiting data collection to 10 events at each site, may have affected the patient cohort included. So it is totally biased because only the first 10 patients were included at each center, which may not be reflective of the actual population which they are dealing with. Now, the study finding may not be generalized to all ICUs. As I said, it is difficult to generalize the findings in all ICUs because the practice and the patient getting admitted can be very different in different groups. These data were collected between 2013 and 16. Now it is 2011, 5 years have passed, so we don't know if the same practice is still going on. No audit of these reports have been done, so we cannot vouch for the authenticity of data that has been produced by the authors, because there were so many centers and without any audit to know whether the actual data is being presented, especially when the mortality rates, reintubation rates and other data from India shows extremely low values, while internationally all of the other centers are showing at least 10 to 11%. Authenticity of data, as I said, remains questionable. Now, to take home message, the conclusion is that it is an extremely robust data that has been presented from almost all across the world. So we know that what is the practice worldwide. There is some idea. Before that, this paper we didn't know what is being done worldwide. Now we know how many patients are undergoing tracheostomy, how many are undergoing spontaneous breathing trials, how many are failing, how many are getting reintubated. So these things can be utilized by individual ICUs for their quality initiatives, and keeping these as benchmarks which can be reproduced in their ICUs. Thank you for your patience, and check our website for further information.